bias due to measurement error or misclassification in the exposure window. She's also interested in risk-based monitoring of multi-center investigations to enhance research quality. So I pass it over to the tech people to put on the lecture for us.
Hi, everyone. I'm Donna Spiegelman, Susan Dwight Bliss Professor of Biostatistics and the Director of the Center for Methods and Implementation in Prevention Science at the Yale School of Public Health in New Haven, Connecticut. If you'd like to learn more about our center, you click on this link here, although hopefully not right now, but maybe after this lecture is over. And if you'd like to be in touch with me after this lecture, please feel free to email me at this address. Implementation science studies should be rigorous, rapid, and relevant. By rigorous, we mean that the results from an implementation science study ideally should be of as high a quality as any other study from which causal inferences are to be made. And in a very important way of ensuring rigor in an implementation science study is to ensure that it's designed well, hence the topic of this course. Rapid is another key feature of implementation science studies. Implementation science is policy-driven, program-driven, driven by immediate, urgent public health needs for which there are evidence-based interventions that are not adequately scaled up and scaled out within countries and between countries. And the point of the concept of rapidity is to get these studies done as quickly as possible so we can get these evidence-based interventions out and increase public health as quickly and efficiently as possible. Finally, there's the concept of relevant. And what we mean there is, again, that implementation science research is driven by policy and program considerations. It's driven by the need to scale up evidence-based interventions. The topics are not driven by individual research interests of academic investigators. Rather, public health drives the agenda. And us as implementation scientists, our job is to take this agenda and ensure that rigorous and rapid studies are conducted. And as such, implementation science studies should consider, first of all, they tend to be guided by implementation science theory, models, and frameworks. Implementation science is very frequently about behavioral change. And behavioral change, the ideas of behavioral change are deeply embedded in the fields of psychology, sociology, political science, organizational development, and so forth. And these disciplines have very well worked out theories and models and frameworks that guide the way we might think of and investigate what sorts of barriers and facilitators there are to impeding and increasing the scale up of evidence-based interventions, and how might we adapt them to new contexts to make them even more effective, more efficient, and more scalable. Similarly and related, implementation science research is typically multi-level. And by multi-level, what we mean is that there are stakeholders at multiple levels. And in fact, in most implementation science studies, the stakeholders are not limited to even one or a few levels, but in order for evidence-based interventions to be effectively and efficiently scaled up and scaled out, we need to inquire as to the barriers and facilitators at all of the levels and address and adapt the interventions to maximize their uptake at these levels. And the levels might start with the sort of traditional levels, the level in biomedical research, which would be the clients or patients and their families and social networks. Again, we extend that out even beyond the individual clients, because often issues such as adherence and initiation and uptake not only involves individual patients, but is greatly influenced by their families, their partners, and others in their social networks, neighbors, friends, coworkers, and so forth. Then the next level of stakeholder are healthcare providers, and that would also frequently span the full range from the most highly trained specialized medical doctors to community health workers with perhaps quite a limited level of education, with maybe passing, say, a 2 or 3 month training in some specific area. And then the next level would be organizational leaders. Those could be the administrative directors of health facilities. They could be district and sub-district leaders. They could be leaders of higher levels of the National Health Administration and so forth. It may also involve policymakers, which could include people in government that are not necessarily, don't necessarily identify themselves as part of the healthcare system at all, such as elected officials, mayors, city councilors, and so forth. Then there's the organization level, which could include, say, the hospital, the facility, the public health community, and then finally the entire public health care system. So again, implementation science study designs need to consider all of these multiple levels when designing designing studies and developing interventions most likely to succeed in the long run. Implementation studies are typically dynamic in that an implementation process typically goes through stages. For example, if we're thinking about increasing uptake to national cervical cancer guidelines, we might start with what are all the factors and processes that lead to women being screened for cervical abnormalities. Then, among those who are screened and found to be negative, having no abnormalities, when do they need to be screened again? Because the screening process ideally is one that's repeated multiple times over a woman's life course, and how often might depend on what the outcome was. If the woman is positive, she needs to be followed up. She might need some more detailed evaluations, such as colposcopy. And if the colposcopy shows further abnormalities, there might be some kind of treatment, such as colposcopy to remove those cells. And so what we would find is that there's a treatment cascade, step by step, through a whole possibly complex process in which finally we would get to the overall end goal of prevention of cervical cancer incidence and mortality. The timing of delivery of intervention components can be as important as the delivery of them itself. So if a woman screens positive, it's not just a matter of whether she was followed up and received further cytology and possibly colposcopy, but it's how long after that positive finding did that happen. As we know, cervical cancer is an evolving disease, and the longer the time is between the abnormal result and the possible subsequent treatment, the more likely it is that the woman may have developed more invasive cervical cancer that might be more difficult to treat. So again, implementation science studies may be looking at complex implementation processes going through stages that oftentimes are nicely summarized through a treatment cascade flowchart, and that flowchart in many cases needs to indicate not just a yes, no as to whether the required action takes place, but the time between required actions, with attention to required actions taking place within desired time guideline suggested time intervals. Then finally, another consideration for implementation science is that when we design them, typically the intervention assignments are at the group level, not as in a RCT at the individual level. So we might be assigning intervention components at the provider level, at the district level. We might potentially be attempting to intervene at the policymaking level, at the hospital level, and at the entire healthcare system level. And those are all group level assignments in contrast to individual level treatment assignments. When we have group level assignments, there are certain types of study designs that are relevant and some new additional design considerations that must be followed. When selecting a study design, and we will get shortly to some of the design options available in implementation science that take this into that take these various points into consideration, we need to consider the research question, the type of clinical or public health intervention, which of course relates to what are the different levels at which the public health intervention operates. What is the implementation strategy, its feasibility, its cost, the personnel that are involved, the settings in which the intervention must take place, who are the stakeholders, what are the logistics in conducting study option A versus study option B, who are the target populations of interest, how quickly do we need answers, are there ethical considerations involving informed consent and randomization and so forth? What kind of data will feasibly be available? And what kind of funding is available to support the research? So one type of design that is of interest in implementation science are a whole group of what we might call experimental study designs. And when we think of experimental, what we mean is that there is a randomized experiment of some kind that takes place. Typically, whenever there is randomization of human subjects, there may be ethical considerations that need to be considered. And sometimes these ethical considerations might lead to the study design not being feasible. For example, if we wished that the ideal design might be an individually randomized study, but we're considering 250,000 pregnancies, as was the case in a study I recently participated in that was conducted in Dar es Salaam, Tanzania. It wasn't feasible to individually randomize 250,000 women. So then we might think of a cluster randomized study. So instead of individually randomizing each one of the pregnancies, we might look at, say, 60 clinics in which deliveries are taking place, and we might randomize some clinics to the intervention, and other clinics might be randomly assigned to continue on with standard of care. That's called a cluster randomized controlled trial. And sometimes that's indicated by the term CRT, cluster randomized trial. And then the second C gets crossed out. So it's a little confusing because individually randomized controlled trials are typically called RCTs. And then cluster randomized trials are often abbreviated by CRTs. Next, we have the pragmatic randomized controlled trial, which is very closely related to the cluster randomized trial. And soon I will show you a slide that will just point out some of the subtle differences between cluster RCTs and pragmatic RCTs, which are a type of cluster RCT where the focus is much more based on external generalizability beyond the groups or the clusters that were included in the design, versus in a cluster RCT, there still might be tighter controls of experimental conditions. So there's greater internal validity, but possibly less external validity. And then finally, there's the step-wedged cluster randomized control trial, often abbreviated by SWD. Okay, so we're talking about experimental study designs, and we discussed randomized controlled trials, which are abbreviated by RCT. They are individually randomized, and they tend to be used for efficacy research of experimental drugs, therapies, and devices. Then we have cluster randomized controlled trials, which are often abbreviated by the acronym CRT. They're very closely related to pragmatic trials. I'll define some of the differences in the next slide. And those occur, and they're the most common experimental study design and implementation science, because typically, as I mentioned, with the multi-level nature of implementation science studies, we need to compare interventions that occur at multiple levels, not just at patient levels as in individual RCTs, but also in, say, practice levels, facility levels, hospital levels, district and sub-district levels, and so forth. And when the interventions occur on that level, the randomization must happen at that level group. So half the hospitals will be enrolled in standard of care, and half the hospitals will be enrolled in a new intervention to prevent, for example, emergency department visits within the first 6 weeks after delivery, for example. And then there's another design called the step-wedge cluster randomized trial, abbreviated by the acronym SWD. And in that case, what we randomize are usually groups to patterns of when the new intervention will roll in. So everybody starts at standard of care, and then the random group one will then say in the next time period, go on to the intervention, while all the others continue on standard of care, and so forth. And I'll be saying more about that shortly. So first we'll talk about pragmatic study designs versus cluster randomized designs in general. And this PRECEDE wheel has been proposed, and here are the citations for this. And this wheel ranks a study, and you can do this with your own study, with respect to 9 constructs. And with each construct, you can rank your study, where 1 means very explanatory, more efficacy oriented, and 5 means very pragmatic. So the contrasts include eligibility, who is selected to participate in the trial, and a 5 might be there are no exclusion criterias, which is the optimal, because in real life, in public health interventions, typically no one or almost no one is excluded, versus 1 where there's a very long, complex set of exclusion criteria. And this is typically what we see in efficacy trials of experimental drugs and treatments. The next one is recruitment. Again, 5 would mean very pragmatic, 1 very explanatory. For example, a very pragmatic recruitment strategy wouldn't use sort of extra incentives or methods of reaching out for people to join the trial and so forth. It would take everybody who comes in a rather passive manner, and ideally have be set up in such a way that there's the trade-off between this and sort of ethical issues, but where there is no need necessarily for people to opt in or opt out, because interventions that are being compared are, for example, all within kind of the standard of care guidelines and so forth. Settings, Again, a very pragmatic trial would be in, public facilities, public health facilities, not private academic research facilities, organization, what expertise and resources are needed to deliver the intervention. If we need a highly specialized, highly trained research team, that's going to be a very explanatory trial versus implementation science trial in which the deliverers of the intervention are the regular employees of the healthcare facility or organization. Flexibility of the delivery, and this has to do with, again, adaptation in a very explanatory type of trial. There would be very strict protocols for how the trial would be conducted. There would be no opportunity for the deliverers of the intervention to adapt it to suit the context and needs of the various stakeholders in the intervention setting. Similarly, flexibility in adherence and adherence monitoring, whether the measures in place. A very pragmatic trial might use standard records, whereas a very explanatory trial might take blood measurements to ensure that trial participants have sufficient levels of the drug, for example, tenofovir in a PrEP trial in the participants' blood at various time points along the trial. Follow-up, how closely are participants followed up? In a pragmatic trial, again, we would use standard records and record keeping from the hospitals and the healthcare system versus a very explanatory trial where there would be special measures in place and maybe a great deal of extra resources spent to ensure full follow-up. Primary outcome, how relevant is it to participants? That calls outcome the whole concept of patient-oriented outcomes, in which outcomes such as satisfaction with healthcare, having the experience of being treated with dignity and respect, and so forth, are held as equally important outcomes as the health outcome. As it turns out, it's been found that in many situations, those sorts of outcomes are of equal importance to patients. In an explanatory trial, we might just be looking strictly for the biological outcome of the intervention, whereas in a pragmatic trial, we would hold these more patient-oriented outcomes as highly important. And again, implementation science studies would tend to be, for the most part, pragmatic trials that would rank high on this PRECISE scale. Another type of experimental design, the step wedge cluster randomized trial. So this is a schematic just to show you visually what happens. And this schematic came from I think illustrates a study that was conducted in Washington State of an enhanced methods for reducing sexually transmitted disease risk among those who are at high risk for such diseases and infections. And let's say there were 5 facilities involved, 1, 2, 3, 4, 5. We throw the dice. Facility 1, everybody at baseline is observed. So we have outcome measures of standard of care, let's say STD rates, under standard of care for all the studies for, say, the first 4 months. Then we throw the dice, and it turns out facility 1 starts the intervention. And now we see that facilities 2, 3, 4, 5 are still in standard of care. So we have a randomized comparison at time 2 at the group level of, say, at sexually transmitted disease rates in facility 1 compared to the others, that's controlling completely for time and fully randomized. We also, as you notice, can compare before after in facility 1. We have a pre-post comparison of STD rates of clients in facility 1 at baseline under standard of care, and then during the 4-month intervention period in facility 1, we can see in a before-after type of comparison how the STD rates compare. So an interesting feature of step wedge designs is we have between cluster comparisons at each time. And here at time 3, now facility 2 got rolled in, and we can compare at time 3, completely stratified by time. We can compare STD rates between the 2 intervention facilities and the 3 control facilities. And then facility 3 gets rolled in, facility 4 gets rolled in, and then finally, at the end, all the facilities are in the intervention group. And one thing, there's 2 very attractive aspects of the step wedge design that have made it very popular. So one is that when there's evidence in support of the intervention, it's attractive to facility directors, the health system, political actors, and so forth, that although we're conducting a randomized study, a randomized implementation study, or a randomized effectiveness trial, all facilities will have the intervention at the end. In comparison, a parallel group randomized trial will randomize half the facilities to control, half the facilities for intervention, and follow them. And the control facilities will never get the intervention unless it's decided at the end that the intervention is beneficial and it's rolled out to all the facilities, both within the study as well as outside. And because of that, we say there's resistance to a parallel design where only half the facilities, hospitals, and the patients and providers within receive the treatment and half not. So there's sort of ethical and sort of political reasons why a step wedge design can be very attractive. The second is when the treatment or intervention is a service delivery or policy change that does not require participant consent. And this is a controversial topic. Some people might argue that even in those situations, participant consent might be required, whereas others have argued that service delivery and policy interventions do not require individual informed consent of the participants. And then a third reason, which is more of a technical one, is that the intra-cluster correlation, or ICC, if it's high or the cluster size are large, a step wedge design will often have higher efficiency over the parallel design. So there's statistical reasons as well why that might be useful. Some situations where a step wedge design might not be desirable are, one, when the intervention is when the step wedge design is a cohort design, meaning that we follow people once they're in a facility, they're followed over time. And then when their facility rolls in, let's say participants that roll at the beginning of the study. Let's say I can even go back a little. So let's say participants enroll here. Participants enroll in time 1 in facility 1, but we're following them maybe for the entire time for say HIV incidents. Well, what happens when we get to time 2 and the facility switches over to the intervention? If the participant hasn't gotten HIV in this first time period, they're still at risk at the second when their facility has transitioned into the intervention. So do we code this person as being in the intervention group or the control group? And it's a little tricky. It's unclear how best to code them. So we might say we're going to code them to be in the intervention group because that's what they were assigned to when they enrolled into the study. But then we might have a problem with survivor bias because only those who make it to time 2, 3, and 4 are in these various clusters are going to make it onto the intervention. And then we don't actually have strictly a randomized comparison anymore. So for this reason, we say if the intervention or the step wedge design is a cohort design, we have issues with selection bias potentially, and we don't have good methods for calculating power or adjusting for the survival bias. And then finally, Another reason we might not like a step wedge design is if, say, we could randomize facility 2 to roll over to the intervention at time 3, but what if they can't do it? Now, they may decide they don't want to do it, or they may decide it's really too hard, they don't have the human resources, and they really want to wait till time 4. So if we're going to have these kinds of issues of the groups, the randomization groups in the step wedge design, not necessarily being compliant with their randomization assignment, the step wedge design might not be a good option. Now we're going to talk about designs and implementation science when we can't randomize the implementation condition. So, of course, the first set of designs would be something you may have learned in epidemiology if you've taken courses, epi courses. They're observational study designs. So the classic types of observational study designs are cross-sectional studies, cohort studies, and even case control studies. For example, we may have information in the electronic health records about different sorts of implementation package components that may or may not have been implemented in different places at different times. And those are essentially time-varying exposure variables in a cohort study or a cross-sectional study, and all the methods at hand for causal inference in epidemiologic research can be brought to bear to make inferences, hopefully rigorous causal inferences, about the impact of these different intervention components on outcomes. There's no randomization, no manipulation. We're just simply observing different aspects of interventions within health systems as recorded in the records. And a lot of information can be gained from that and shouldn't be underestimated in any way. It will be impossible to study every single set of and package of interventions we might want to consider for all sorts of different health outcomes. Randomization just simply won't be possible for all of these different things. And observational methods will be used, and everything you've learned or can learn in epidemiology can be brought to bear to address very important implementation questions in a rigorous causal manner. Then we have the set of quasi-experimental study designs. So we talked about, with the step wedge design, the before-after aspect of the step wedge design, because you can have, say, you could study in a single facility, you could follow and record outcomes under standard of care for, say, the first 6 months. You can roll in an intervention and then follow and observe the outcomes in the next 6 months. That's exactly a before, after, a pre, post design. And that's called a quasi-experimental design. It's quasi-experimental because we haven't actually randomized to the pre and post periods. But what we're doing is we're using either the individual participants, if there's repeated measures, or the facilities as their own controls. And to the extent that the characteristics of the individual clients and the facilities don't change over time, they serve essentially almost perfectly as their own controls. And under that assumption, we have a causal inference. Sometimes, however, these characteristics do change over time. In fact, secular trends in outcome rates are well known. And in order to adjust for those secular trends, we might have a controlled before-after design, which is also called a difference in difference design. So we have the before-after that I just mentioned, say in some facilities where we looked at the effect or the outcome before and after in intervention in facilities that were going to become subject to the intervention. And then we have a whole set of control facilities where we can look at the before-after at the same time that the intervention facilities changed into the intervention state. And then we can control for time trends by after minus before in the control facilities, minus after minus before in what was to become the intervention facilities. And that's an even more rigorous quasi-experimental design, where again, there was no randomization, but we're using other design principles to make rigorous, nearly causal inferences. Another approach is the interrupted time series design. Now that's where there are multiple assessments prior to and following the introduction of an intervention. And we look to see what the time trends are and whether there's jumps in either the trend or the level after the intervention rolls in. And I'll show a graphic illustration of this on the next slide. And then finally, another design, which there isn't really time to go into, I haven't seen it to be as popular in implementation science, is the regression discontinuity design, where individuals or groups are assigned to the intervention or control based on a score or metric, such as their CD4 count. And that CD4 count becomes essentially an instrumental variable for the intervention. And instrumental variable methods and causal inference are very important in this sort of design. So here's a schematic for the interrupted time series design. So what we have is before the intervention, we have the outcome measure. And so often, if nothing else is happening, we might expect there to be no change at all. Then we have the counterfactual that we assume after the intervention, we would have expected that this would just trot along as it had before. And then the intervention rolls in and we might see a jump, like a decline in the outcomes, say in mortality rates or cervical cancer rates. And then we might also see a time trend in which the change or the rate is continuing to decrease even after the intervention. So there might be this jump and then no change, or there might be a jump and then a change, or there might be no jump, but then just a change in slope, and then you'd see this line meeting this one, or you might have both, as in the schematic. And then there are statistical methods available using standard regression models to assess whether there's been a jump, whether there's been a change in slope, and whether there's been either or both. And it's a very nice method. Here's a paper for more information if you wanted to read more about this approach. There's also other emerging innovative designs for implementation science that you might hear about. One is the multi-phase optimization strategy, otherwise known as MOST. Another is the sequential multiple assignment randomized trial, or the SMART design. I'm actually not going to go into that today. I wanted to mention it so you might hear the term maybe for the first time. I don't think that it's that relevant for implementation science, but it's used to develop dynamic interventions, which seem to be more relevant for medical care than for implementation so far, although it has been used in implementation science as well. And then the Learn as you go design, which has been developed by I and my group and is very important it provides a rigorous way for adapting multi-component, multi-level interventions. So here's a schematic slide that describes the multi-phase optimization strategy, or MOST design. It's got 3 phases: preparation, optimization, and evaluation. In the preparation phase, it lays the groundwork for optimization. And what takes place is that the conceptual model, and that's where we're talking about the implementation science theory or frameworks such as REAIM or EPIS and so forth, would be chosen and adapted for the current situation. We might have a multi-component intervention. We identify the list of those components, say to improve compliance with cervical cancer screening guidelines. We'd be looking at reviewing the lists for who are women who are enrolled in various clinics are eligible for screening. When had they been last screened? then how are we going to reach out to them? By text messages, by mailing them a letter, by sending a community health worker to their home, how many, or phoning them, how many phone calls, how many text messages. Maybe when women come in, something would appear on the computer that the provider might be using, saying this patient has never been screened or hasn't been screened in 5 years, and then the provider is asked to schedule their screening visit or send them right on to the screening clinic and call a screening navigator to come in and help them get to the clinic and so forth. There's many, many components that can be considered, and the whole comprehensive list is identified. Then there may be pilot tests conducted. There might be qualitative research to assess the acceptability, feasibility, and appropriateness of these different components. And then the optimization criteria might be chosen. So we might simply, in our next phase, want to optimize the components to kind of hone down and greatly shorten the list of possibilities, say, to choose the most feasible and acceptable to then go on for the next phase of testing. So in the optimization step of most, M-O and S-T, so now we're in optimization. So we build the optimized multi-level, multi-component intervention. Optimization trials are conducted. They might be factorial experiments, fractional factorial experiments, and so forth. Those two are the most popular. And that's where we might say, okay, if there's 4 different components, there's 2 to the 4 or 16 different combinations of those. And we can, in very short, say 1 month or 2 month studies, try all 16 of these and see which ones are ranked as the most feasible and acceptable among, say, clients and frontline providers. And then we choose the most feasible and acceptable to then go on if the optimized intervention is expected to be sufficiently effective. If we don't get to combinations that are ranked high enough on our optimization criteria, we might have to go back to the drawing board and look at our list again and then re-optimize. But once we get to the point where the optimized intervention is expected to be sufficiently effective, we take this package that would be, say, a combination of 4 different components, and we run a standard randomized trial, whether it's a group randomized trial or a step wedge design or an individually randomized trial is relevant, usually not, using the standard principles that we had talked about for step wedge and group randomized trials. And that's what the most strategy is. And how it's different from the randomized studies we've talked about before is that it has these very, I think, very smart preparation and optimization phases. So we're giving our intervention package the very best shot of succeeding in the randomized trial where we're investing a lot of resources. Next, we want to talk about adaptation. So now that we're thinking about complex multi-level, multi-component interventions, such as the example I just mentioned, where, say, to increase adherence to cervical cancer screening guidelines, with all the many ways that that could be done, we can, say, through most, come up with an intervention package with 4 components. Let's say a woman gets 3 text messages. If she doesn't come in, she gets 2 phone calls. If she doesn't come in, she gets a visit from the community health worker. And then if she does come in, and if she comes into the doctor's office for other reasons, the doctor or the provider gets a message on their computer giving the woman screening status. And if she hasn't been screened ever or hasn't been screened in a time frame that's suitable for the screening guidelines, she is sent on she's given an appointment for a screening clinic. So those are 4 different components. Now, it might turn out that as we start out with that approach, that maybe after, say, 6 months or a year, it becomes clear that maybe this approach can be adapted in certain ways to make it even more effective towards achieving the implementation goal of satisfying, of achieving being compliant with or adherent to national cervical cancer screening guidelines. So we might want to adapt it. And this is where we have the tension in implementation science between what's called fidelity and adaptation. Fidelity is one of the important implementation outcomes, say in the Proctor model, which you may have heard of in other synchronous or asynchronous sessions in this series, but it has to do with following the protocol. So as we talked about in an efficacy trial, it's absolutely essential that every aspect of the protocol be followed, whereas in a pragmatic effectiveness trial, we might have a broader approach to what the protocol is, and we may allow for individual adaptations as needed, as long as the basic functions of the protocol are satisfied. So you might want to look at this paper, which talks about reconciling fidelity and adaptation, evidence-based practice implementation, and there's no right answer. There's quite a lot of complexity and debate about this, but maybe the take-home message would be, in implementation science, it's well understood that both fidelity and adaptation are important. So what I have here is a very complicated slide, and the main take-home message is, if you are to adapt, and we might basically assume that we all will in implementation studies, and even that we all should, the most important thing is to record what the adaptations are, when they occurred, and to what extent. So this slide provides a framework for reporting adaptations and modifications for an implementation study. And you might refer to this paper, which gives a detailed exposition of this framework. And it's quite comprehensive. And they talk about recording on the process level: when did the adaptation occur? Were the adaptations planned? Who participated in the decision to make the adaptation? What was the goal of the adaptation? What was modified? Was it the content of the intervention? Was it contextual modifications? Was they modifications to training and evaluation of the intervention? At what level did the adaptation occur? What is the nature of the content modification, and so forth. And then the reasons. There could be social and political reasons. There could be organizational reasons. There could be provider reasons. There could be recipient reasons. And so ideally, if all of these things as relevant, and they're not all relevant to every implementation study, but to the extent that these are relevant, my only suggestion to you all is to try to come up with a systematic way to record them, so we can later go on and analyze them and look at the impact of these adaptations to the initial prescribed intervention and assess to what extent, probably using causal inference methods, because these are not randomized adaptations anymore. They're adaptations based on subjective and objective data, qualitative and quantitative, that might exist at the time. And so then again, to assess rigorously the impact of these adaptations, we'd use the standard causal inference methods for observational research that are taught in epidemiology courses. Now I'm going to talk briefly about the Learn As You Go design. I'm very proud of this design. Here is its published reference. And the way this design works is there's several steps. First of all, the intervention is a package consisting of multiple components. What we do is we predetermine several stages in the LAGO design. So maybe every 6 months or every 9 months, we'll say we're going to evaluate the intervention package as it was delivered, and then we're going to do an analysis and decide whether we want to reconfigure and optimize the intervention based on the data that's occurred up to that point. Then we roll out the intervention in the next stage. We analyze it again at the end of that stage. We optimize it. We roll out the next stage with the newly optimized intervention until, ideally, until the study, basically the study resources are exhausted and or the outcome goal is achieved. So I'll have an example. So this is a way to adapt, as we were talking about on this slide. This sort of adaptation kind of is a way of recording and through observational methods, assessing the impact of the necessary and chosen adaptations that might occur. The LAGO design formalizes this in a rigorous way so that the randomized nature of the trial is preserved. And at the end of the study, we'll have a formal statistical test with the guaranteed type 1 error that the intervention package, the null is the intervention package has no effect, versus the alternative it does. And we can do that analysis. We'll also be able to estimate the individual effects of the intervention components. We'll have a prediction rule to decide how to further adapt the intervention to achieve the intended outcome goal in the future. And we may also optimize, potentially we could also optimize as we go along cost effectiveness. So here's an example of the Learn As You Go design applied to the Better Birth Study. The Better Birth Study took place in Uttar Pradesh, India, and it was testing a multiple component intervention package to improve process and outcomes for mothers and newborns. And the idea was to use the safe childbirth checklist that was a process outcome to increase its uptake. At the start of the study, although it was part of the national guidelines, the safe childbirth checklist, which is recommended by the World Health Organization, wasn't really used, was used by very, very few of the facilities that were included in this study, which was in total 36 centers or facilities, birthing centers. And so the goal was to improve uptake of the safe childbirth checklist, which involved doing, a certain number of evidence-based interventions to improve maternal and early child health outcomes at the time of delivery and closely thereafter. And then the ways of doing that included, sort of the standard implementation science types of interventions, including a launch of a certain duration, which involved training and motivation and addressing concerns and so forth. Then there were coaching visits where more highly trained birth attendants and supervisors visited the facilities and worked with the individual birth attendants to help them improve their compliance with the Healthy Childbirth Checklist and all of its different elements. And then there was audit and feedback of the birth attendants. And then there was district and facility level leader engagement in the entire intervention and supporting and attending the launch, supporting the coaching visits, reviewing the audit and feedback data and so forth. So it had these 4 components. And the study, it wasn't a LAGO study because LAGO studies are a new development that haven't really been used in existing studies yet. But again, I'm introducing it to you as a way for rigorous approaches to adapting, conducting the necessary adaptations and implementation studies that are going to happen anyway. So this study had 2 pilot studies in stage 1, let's say LAGO stage 1, 2 in LAGO stage 4, and then 30 in LAGO stage 3. And qualitative and quantitative data were used to add up the intervention package at the end of each one of these stages. And so there was 120 sites in all among 24 districts, and there were almost 160,000 deliveries during this period. And the goal was to get the WHO Safe Childbirth Checklist used in at least 90% of the births. We also looked at some other outcomes adherence to oxytocin administration, 7-day mortality, mother and child, and the costs, for example, the cost for coaching session, and so forth. And so in our example, in our paper, we show how if LAGO had been used, what the outcomes would be, and what the optimal intervention would be using the LAGO approach at the end of the study. So the next design that I want to cover in this talk is what's called effectiveness implementation hybrid designs. And these are unique to implementation science. And an example of a hybrid design right here is the Better Birth Study. If the primary outcomes were, say, uptake of WHO Safe Childbirth Checklist, which is a process outcome, and 7-day mortality, say maternal mortality, which is a health outcome, and the study was powered equally on both of these endpoints, that would be a type of hybrid design. In fact, it would be a hybrid design. There's hybrid design type 1, 2, and 3. And the goal of these hybrid designs is to accelerate the transition from effectiveness trials to implementation trials. So here's how I was saying, in this example, we have hybrid design 1, 2, and 3. And I said if Better Birth had put equal weight on the scale on the clinical effectiveness outcomes, say maternal mortality or 7-day infant mortality, at equal weight on one or both of those, and on, say, increasing the uptake of the safe childbirth checklist from, say, 5% to 90%, that would be a hybrid design type 2. But if it was a hybrid design type 3, Better Birth would have said, we're powered to increase uptake from 0 to 90% of the safe childbirth checklist. That's what we're powered for, but we're also going to look as a secondary endpoint on maternal and 7-day child mortality. That would be a hybrid design type 3. And a hybrid design type 1 is the closest to an effectiveness trial. And in a hybrid design type 1, we would emphasize and power the study for, say, maternal mortality, and then the uptake of the safe childbirth checklist would be a secondary outcome. And so this is a very nice approach for implementation science, where I personally like the type 2 design, because even though we'd say it's an evidence-based intervention, and you can in implementation science have primary outcomes that are just process outcomes, like we can say that safe childbirth checklist is an evidence-based intervention. We don't even have to look at maternal mortality or 7-day child mortality. We know if these practices are routinely and consistently applied, we will drastically reduce maternal mortality to the levels that are seen in, say, Sweden and Norway. So all we're going to look at is the safe childbirth checklist. Well, you know, context does matter. And it seems like a good idea just to make sure, even though the intervention is evidence-based, if we have a hybrid design type 2 or a hybrid design type 2, we can still make sure that we're getting the desired clinical or health effectiveness outcome. At the same time, we're optimizing the implementation strategy. And I think that's a nice way to go. But you all can know that, say, within the National Institutes of Health in the United States, hybrid design type 3s are fully acceptable as fundable research designs as an implementation science approach of evidence-based interventions. So I'm going to wrap up here and with a few take-home points. If you want to read more about implementation science, here are a few books that you might want to look at. We want to remind everyone implementation studies require consideration of context, multiple levels, multiple components, and the timing matters as well as what the components are. When it comes to choosing an implementation science study, you might systematically identify and rank potential study designs, then decide which one to go forward with. When you can, consider randomization in real-world rollouts when possible to increase rigor, and the step wedge design is a very nice way to do that. Consider innovative approaches such as LAGO, hybrid designs, the most approach, if they're relevant to your study. And then if randomization isn't possible, there are quasi-experimental and observational designs available. This is the focus of causal inference. And please don't let the perfect be the enemy of the good. There is so much we can learn from the data available using observational information from the health records and other routinely available administrative sources. There's no way we're going to be able to study everything we need to study through randomized designs and even quasi-experimental designs. So don't eliminate observational studies in the implementation science setting. Thank you very much. I'm happy to take questions and comments during the synchronous period of these sessions. And I'd like to give a big thanks for assistance with these slides to Greg Ahrens, who's a professor at the University of San Diego, Department of Psychiatry, and the UC San Diego Dissemination and Implementation Science Center. Thank you very much. And I look forward to our live session.
So thank you, Donna, for coming on board. Thank you for that wonderful talk. And I'd like to open the floor for questions. Due to some time constraints, we can probably only allow one question. If you'd like to come up to the microphone so that Donna can hear your question. Any takers? Oh, you've got one from the back there. Okay.
No. I'm coming up from primary care. Thank you for the comprehensive lecture. It's very interesting and I learned a lot. So I'm doing a study I'm doing a study trying to improve care of asthma in the health clinics. And we have intervention which is improving the care at the clinic, is one component, and the other one is actually at schools, whereby we actually try to bring the children who have asthma to the healthcare center. But both of these components has not been tested. It's still in the disability study. So I just want to ask, for that component in school, should we conduct it in to test in to link it to a healthcare clinic which already has a good asthma care, or should I link it to this second component which is still under testing? Which has not, which we are doing it together. Should we test it together as two components separately, or should it be done separately? Yes.
Was that clear?
Yes, I heard. Yes, so thank you very much for the question. And before I answer it, I'd like to say hello to everybody. And I thank you very much for listening to my lecture. And I want to say I'm sorry that I couldn't make it to Kuala Lumpur this time, but hopefully next year I'll be able to attend. And yeah, it's a pleasure to see you all remotely in the room. It looks like a great group. And yeah, so in terms of the question, it seems like, this is what you might call like an intervention package that has a school-based component and then a clinic-based component. And the question is whether you want to whether we want to assess the impact of the school component separately, the clinic component separately, and then the two together compared to, say, standard of care. So, the ideal design for such a situation is a 2x2 factorial design. If you have the resources and flexibility to do that, where you might randomize school clinic pairs to standard of care, school-based component only, clinic-based component only, or both school and clinic component. And then you'd be able to assess the effectiveness and the cost effectiveness, ideally, of the two components separately, and then see what kind of synergy they might have together. So I don't know if that's an option.
field can help us.
I'm sure Donna will be more than happy for you to email her for more ideas as well.
Absolutely.
All right. I think we've come up to that 5 minutes. So sorry, Donna, we got you on.
No problem.
For just 5 minutes, but we hope to get you here next year for our next bootcamp. All right, thank you.
Okay, bye everybody. Great seeing you all.
Good to see you.
Take care.
Okay. So we'll now move on to our second live stream keynote lecture. So this one will be on rapid qualitative methods in implementation science research.
Hi everyone.